So our next speaker here is Hormozd Bozorgchami, and he is one of our cerebrovascular trained stroke neurologists. So we're really happy to have him part of our team. He's also in the middle of an interventional neuroradiology fellowship, so he knows his way around all aspects of stroke. But before we launched into in more depth in the different etiologies of the various strokes, I think you all know that altered mental status can be so many different things. So we have a presentation here where all these kinds of mimics and ciphers, and I'm happy to turn this over to Hormozd. Thank you.
Thank you. Hormozd Bozorgchami. Can you guys hear me okay? I'm kind of tall from the mic. I actually had 2 stroke mimics last night, so if I'm a little sleepy, I apologize. So today, I just want to go over my disclosures. I don't have any. I'm too young for that. In terms of the main disclaimer of this talk is I don't want you guys going after this talk and thinking everything you see on the field is now not a stroke. So treat everything as if it's a stroke, and then let everything else kind of get proven otherwise. So just mainly going to talk about some of the difficulties in diagnosing stroke and some of the key points in history. I always had attendings when I was a resident yell at me when I would first look at the CAT scan instead of looking at the patient. So really trying to emphasize history taking in neurology, especially in cases like TIAs, and we'll get into that. And then I just have a few stroke case examples, and then just a review of some of the common mimics. So for the purpose of this talk, we'll say that the stroke definition is basically a sudden onset of a focal neurological deficit that it can be a vascular etiology lasting more than 24 hours or causing death. And then we'll call it TIA anything that lasts less than 24 hours. Now, there's a lot of debate about this because we have more and more sophisticated imaging, and oftentimes patients with TIAs are found to have little ischemic strokes on the MRI, and so people are like, well, should we call those strokes or should we call them TIAs? But I like the clinical definition, so I'm going to stick with that. And the main thing I always emphasize to patients is that TIAs aren't mini strokes. They always come to clinic and say, oh, I had a mini stroke 5 years ago. They are brief strokes. They're very serious. They do raise your risk for ischemic strokes. So why is it difficult to diagnose a TIA? Well, the obvious answer is that patients are often normal by the time they come to the emergency room or by the time you guys see them on the field. And you're basically going based on what they tell you. And if you ever try to get history from a patient, I think everybody has dizziness at some point, and everybody means something different. It always means something different for everybody. So it's important to really define, the symptoms and see what they exactly mean when they say my arm was heavy or I have some numbness or. And then when thinking about this, always ask an eyewitness, because patients, sometimes have look at things from their perspective, and if they were a little confused with the episode or something, then they might not be able to tell you accurately what happened. And always wish this would happen someday. We'll see. So some of the common conditions of misdiagnosis TIA: Migraine Aura, Syncope, seizures, definitely a common one. Oftentimes a peripheral nerve palsy even can be mistaken as a stroke or TIA. And then metabolic abnormalities are also a big one. When we looked at a study back in 2005, we saw that 29% of referrals to the emergency room seen by a stroke team were felt not to be a stroke or TIA. To me, that's great. I mean, I like to think that if we get a lot of patients that don't have stroke or TIAs that we see, that means that we're not missing any strokes or TIAs. But the most common thing that's often it's confused with is a seizure or migraine, and then functional disorder. Both the patients I saw last night actually on telemedicine were actually functional, which is it's always fun to try to distinguish that on telemedicine with confidence. But the main question for us is, was it a vascular event or not? We always want to know, when did it happen, but also more importantly, when were they last normal? Because patients are often found down, or a common scenario is that a patient becomes aphasic and then they try to call their family member, and the family member realizes that they're confused on the phone. They drive over, they see that they're not right, and then they call 911. But we don't know if they were like that for 3 hours before they called their family member. And then it's also very helpful to know what they were doing at the time of their symptoms. Were they sleeping and they woke up? Were they out in the yard doing gardening? A common one is being at church during a sermon. I don't know why. I always think it's from the sitting and standing, and then other things we like to know is, was it sudden or gradual? Strokes are often sudden. Sometimes you have fluctuating symptoms that could often be perceived as gradual. And then wanting to know, is it motor involvement? Is it vision? Is there speech? Is there language? Both arms, one side? Were there any associated symptoms like loss of consciousness, confusion, headache? And then if the patient has history of seizures or migraines, obviously. And the main thing I always like to emphasize is that strokes don't hurt. So if they have arm pain or leg pain with their symptoms, it's very, very, very unlikely that it's a ischemic stroke. And then again, trying to distinguish focal from generalized symptoms. So cerebral ischemia, you rarely do you get blood clots that shower everywhere, and all of those blood clots are all symptomatic at the same time. And so it's usually going to be localized. You should be able to localize it to one part of the brain, and it's not going to typically cause generalized symptoms like faintness or dizziness. Sometimes patients can get hypotensive for some other reason, kind of pass out, and then because they were hypotensive and lost blood flow to their head, they have a stroke as a result because they had like a high-grade carotid stenosis on one side. But for the most part, the generalized symptoms don't really go with a stroke. The exception, of course, is the Toppler-Bazar syndrome, which you could talk an hour about that. Patients can present with just about anything. That's why whenever I can't localize where a patient's problem is, I often always try to exclude that with a CT angiogram. And then trying to distinguish between weakness and ataxia sometimes can be tricky when you talk to patients. Really, you have to often see it firsthand, and that really just tells you, could tell you which part of the brain is really affected. And then, slurred speech is different from a difficulty expressing language. Oftentimes, aphasias and dysarthrias are mixed up with patients. And then, of course, just trying to get the sensory symptoms and exactly what are they feeling. Is it loss of sensation or pins and needles? And then the vision change. Patients often think that when they lose vision on one side, that it's from that individual eye. So if they have a left hemianopsia causing left visual field cut, they think it's all coming from their left eye. But in actuality, it might be a left visual field cut. So it's very important to try to distinguish that when you're doing a brief neurological examination. And the main thing is just to see if the symptoms are there when they close one eye or the other, because that could really distinguish, is this a stroke or is this something else, like a retinal detachment or something. And then vertigo, of course. But in isolation, vertigo is very tricky because it's very difficult to distinguish if it's an ear process or if it's a brain process. But typically, my rule of thumb is if they have vertigo in isolation and they look really sick and vomiting, it's usually a peripheral process. And if they have vertigo with dysarthria or double vision or some other focal neurological deficit, then you really have to take it serious for a stroke. And then other examples of nonfocal neurological symptoms, the generalized weakness, lightheadedness, which is always important to distinguish that from vertigo, and faintness, blackouts, and tinnitus, and of course incontinence. This is also something I used to do, but now with digital records, very difficult. So the main emphasis you'll hear throughout the day is time is brain. We always want to do things very quickly and get patients to stroke centers really quickly, but we also want to try to do things ahead of time before we get to the emergency room. But so really don't delay any potential stroke treatment because you're worried it could be a mimic. Again, it's okay if everybody's brought in a presumed stroke until proven otherwise. I mean, that's kind of how we treat things when we look at patients, especially on telemedicine. And so the next few slides are going to be a couple of cases that I saw as a resident fellow. I show a picture of GW just because he has a little facial weakness there and wonder if that's a stroke. So the first case is my favorite case. 52-year-old male has coronary artery disease, hypertension, diabetes, and previous strokes, lots of risk factors for stroke. He was at a church during sermon and had left side weakness, headache, and dysarthria. He went to his local hospital and was evaluated by a neurologist. I'll just say that was me via telestroke. And I clearly saw left-sided face, arm, and leg weakness. He really couldn't move his left side. He was complaining about a profound headache, and went ahead and gave him TPA because he fit the criteria. By the time he arrived at OHSU, he still had some headache, very subtle weakness, but markedly improved. Because he had such a severe headache, thought that was a little unusual, so went ahead and got an MRI scan. But I'll just jump to it. This is an example of his MRI scan. It was negative. This is a diffusion-weighted image, and basically this is what we use in MRI to look for acute stroke. What it looks at is you hit the brain pretty hard with a magnet, and it causes water to move. And areas of stroke basically don't have much water movement, and so you end up having a bright spot there, and that's an area of stroke. This patient did not have any areas of stroke because actually ended up having a complicated migraine. He forgot to mention to me that he has also frequent migraines that cause vision spots, and but he said the TPA cured his headache, so I don't think it's all bad. And eventually sent him home with a calcium channel blocker. But it's a good example, while complicated migraine, even if unless he does this like every 2 weeks or every month or something, you really, with all those stroke risk factors, you can't just presume complicated migraine and not treat them at that point unless you could get some sort of other imaging modality to prove otherwise. So before this image makes you dizzy, go over migraines a little bit. Migraine with aura are these positive symptoms of focal cerebral dysfunction that usually develop over 5 to 20 minutes. The most common are visual scotomas, little bright spots, zigzags in the eye. But some patients can actually develop heaviness in their extremities or tingling, and pretty much any focal neurologic deficit is fair game for these. More and more, we're seeing patients with migraine aura without the headache, which makes things a little more tricky. And of course, they get more common as your age increases, and you might not necessarily even have a history of migraines. But they're usually slow onset and spread and intensify over minutes to hours. There's also a very rare phenomenon called familial hemiplegic migraine syndrome. Don't need to worry about that. It's very rare and very familial. But typically we don't prescribe patients with those abortive medications like sumatriptan or ergots because we're worried that they could potentially cause strokes in these patients. But there's actually more data saying that it's actually pretty safe, but it's still under a lot of debate. So the next case is a 45-year-old homeless man, unknown past medical history, was found down on the street. On exam, he was sleepy, confused, not following commands. He had bruising around his eyes were deviated to the left, he had some left facial twitching, and he wasn't moving his left side to pain. What do you guys think is going on here? All right, I should just go home, because it was exactly a seizure, and it was due to this subdural hemorrhage. And this is a CAT scan, and this area here is the hemorrhage. With a CAT scan, we could kind of age blood, so we could get an idea how long he may have been down based on how bright the blood is. And you have that chart there, and you guys could for your interest, you'll have that in your slide set. So partial seizures can mimic TIAs, but they typically have positive symptoms like tingling or twitching or jerking. And they can also spread over a minute. So oftentimes they'll have tingling in their hand, and then it goes up their arm, and then the whole side of their body. Same with the twitching. They can have twitching initially in their face, and then it kind of spreads to their arm and leg. And they often have amnesia at the event, so they will be the worst historians ever. I mean, you have to really ask an eyewitness about what happened. And they occur without warning from the patient perspective. That's just an example of a seizure on the EEG. And just for another example, that had a 64-year-old woman with 20 attacks of pins and needles in her right arm and leg over 6 weeks. It started in her foot. It felt like water running up her leg, and it was the same every single time, very stereotyped. And she ended up having a brain tumor in MRI in the left parietal lobe. So this is an example of a simple partial seizure. They're typically harder to treat, and they're very hard to diagnose because oftentimes the EEGs can be normal, but they're very stereotyped, and they're actually somewhat hard to treat. These patients, by definition, the simple part of it means that they have no alteration of consciousness or awareness during the episode. And if someone has 20 attacks of TIAs over 6 weeks, they're bound to have had a stroke by then that would have been more permanent. So if someone has that many events, that it's unlikely to be a TIA. And so it's rare to have negative symptoms during the seizures, meaning that they don't get acute weakness during the episode. They're usually, rigid. But after the episode, they can have Todd's paralysis, where they can be excessively sleepy and have loss of function on that side. So it may have been contracted and shaking, and then all of a sudden, when they're done with the seizure, one side could be paralyzed for hours, sometimes even a day. I always look for tongue biting and urinary incontinence. And the big rule is that if they had a big tonic-clonic seizure and they're not showing signs of any recovery within 30 minutes to an hour, I really have to consider non-convulsive status epilepticus in these patients. And just an example of the eye deviation. So I love eye deviation. It often helps localize what's going on, and also kind of helps with the diagnosis. So my rule of thumb is, or the way I remember things, is if the eyes are looking at the hand shaking, that's usually the eyes would be looking at the hand shaking in a seizure, whereas the eyes look away from paralysis in a stroke. If you have a stroke on the left side of your brain, your eyes are going to look to the left and your right side's not going to move, whereas if you're seizing, your eyes will be from something from the left side, your eyes will look to the right side while your right side's shaking. It's kind of a nice little generalization there. So, case number 3. We have a 50-year-old male with no past medical history. He presented to the emergency room with some, quote, mental slowness. He was normal, last normal more than 3 hours prior to his admission, so he was outside of the conventional TPA time window. I think it was like 6 hours out. He went to walk his dog, and when he returned, he was confused, his wife said, and they couldn't find their dog. And then 1 hour after a presentation in the emergency room, he developed acute onset left-sided paralysis, and that's when they called us. We evaluated him and saw that he was just kind of withdrawn, not really worried about his symptoms, had a right gaze deviation, he had some weakness on his left side, and very profoundly having some profound neglect, and he didn't recognize his own arm on that side. So is this a stroke? Well, yes. And this is an example of a CT angiogram. Basically, you inject contrast at time with the scan so that you could get a picture of the arteries. And here, this is the right middle cerebral artery. And here where the contrast kind of cuts off, that little spot, that's a blood clot. We went ahead and removed the blood clot endovascularly, and he actually did pretty well. Case 4. So this is a 58-year-old man, a history of CHF, and he had this known cardiac thrombus, and I actually got called by the cardiac ICU because this patient developed acute loss of consciousness and wasn't moving any of their extremities to pain. They got a head CT and then they called me. And this was about 2 in the morning. It was an intern. They were determined that this was a stroke, but what else would you think to check this time? They went straight for head CT, and this is often your realm. Exactly. Well, pretend we didn't know that. But, so they got this CAT scan. They were concerned that this little spot here on the non-contrast CAT scan was the source of the patient's symptoms, and this is a really old appearing stroke in the right subcortical area. Would not explain the patient's symptoms. And asked them to check the blood sugar. It was 34. Gave him an AMPA D50. Patient miraculously improved. So, well, the reality is that you guys do such a good job at checking these things before patients come to the emergency room that these are things, some of the basic things that we often forget as physicians to check because it's automatically usually checked for us before we get called. So a little bit about metabolic and toxic disorders. Hypoglycemia can definitely cause transient and permanent focal or generalized symptoms. Patients are typically on insulin or some oral or some oral diabetes medications. They can also occur without adrenergic or diaphoresis or some of the tachycardia that is associated with hypoglycemia. Obvious thing, always check glucose and vital signs in any stroke patient, preferably before getting a $1,000 CAT scan. And the main other thing is that often these toxic metabolic disorders can re-express old stroke symptoms. So if a patient had a previous right middle cerebral artery stroke, they had some metabolic issue, and even though they recovered fully from their stroke, they can develop new symptoms of weakness on one side of the body that looks like an acute stroke. Other common metabolic toxic disorders include hyperglycemia. So not only can hypoglycemia cause symptoms, but when you get your patient in the blood sugar in the 400s, that could definitely cause neurologic abnormalities. Same with changes in sodium, calcium, and acid base. And then we always check urine tox screens as much as we can, especially in the younger patients. I've actually had a urine tox screen, the standard one, miss an overdose of soma, muscle relaxant, and I had to get a comprehensive drug screen to find that, but thought it was a Basler stroke because I couldn't figure out what was going on. And ended up getting a CAT scan with contrast, and it showed it wasn't, and then got the comprehensive drug screen back, and it showed soma overdose. And one form of metabolic toxic disorder that is often overlooked is Wernickesencephalopathy. So this is caused by thiamine deficiency. It's usually a prolonged process, and the symptoms are typically double vision, ataxia, and confusion. That's the triad for it. The stereotype med school questions always is that it's seen in alcoholics, but honestly, it's more commonly seen in patients with like gastric bypass surgery or malnourished because they live off top ramen noodles or just don't eat correctly, or have some other metabolic problem going on that's preventing them from taking in enough thiamine. The other thing we see is patients on a TPN where they get their nutrition IV. Often it doesn't include thiamine in the supplement, so if someone isn't giving them a multivitamin with thiamine in it, it can often be forgotten about. It's very treatable with very high doses of thiamine if it's treated early, but if it kind of goes on for a long time, patients end up having permanent symptoms. And that's the reason why we never give glucose before thiamine in suspected patients, because you could really give them permanent neurologic deficits if you do that. So a case of hypoglycemia, another example. This is an 82-year-old woman, history of atrial fibrillation, diabetes, hypertension, and she was offered Coumadin for the last few weeks prior to admission. She was found down by her family. They saw she was a little sleepy, not moving her left side. They actually checked her blood sugar at home. It was 30. They tried to give her some orange juice. It went up to 70. Didn't really see any improvement. Brought her to the emergency room. They gave her an AMPA D50. It improved to 170. She was a little more, perky, but still had persistent left-sided symptoms. And then they called me, and I went ahead and just thought, well, you can't exclude stroke in this patient. Go ahead and give him IV TPA, and then brought her in for an angiogram. And this is an example of a cerebral angiogram. We went ahead and injected from the right internal carotid artery, and you see this contrast going up. And over here, there's a big stroke. There's an occlusion of the right M1 segment, which is the very proximal portion of the middle cerebral artery. After a few passes with our thrombectomy devices, we were able to open this up, and she got restoration of her blood flow. And at 30 days, when we saw her in clinic, she was virtually normal. So just because it's, again, showing an example of how things can work the other way, that even though they're hypoglycemic and have persistent symptoms, when you improve it, you always thought to think stroke. This one was one of my favorites, only because they called me on New Year's Eve at 11:50 at night, which is very upsetting. So this is a 55-year-old obese male. He has history of obstructive sleep apnea, hypertension, and he was watching TV in his chair, and he fell asleep in his chair that afternoon. And when he woke up that evening, he noted numbness and tingling and weakness in his left arm. He had no problems speaking, no problems walking. He drove himself to the emergency room, and he basically had trouble extending his arm and his wrist, and he had trouble opening his hand. No real problem squeezing his hand, and he had some patchy areas of numbness. And I was asked to evaluate him to see if he should get TPA. And the answer was no. He ended up having a Saturday night palsy, which is a radial nerve palsy, probably because he was leaning funny in his chair and pushing on his radial nerve, and caused some injury there. So usually it causes weakness and sensory changes, which in specific dermatomes, and I keep a picture of this on the card in my white coat, just so if patients have patchy symptoms, I could kind of determine if it fits any of these things. And the main treatment for this is just to avoid compression. Depending on how long the compression of the nerve was, the recovery can be quick, or it can take months to, usually months. And then also can consider radiculopathy and plexus injury from the cervical spine injury, and that's all I go on that. So to kind of go over some other generalized things, such as syncope and pre-syncope. So a loss of consciousness is really rare due to stroke or TIA. Now, there can be things that cause loss of consciousness that end up also causing strokes, but not necessarily that the stroke causes loss of consciousness. So the only way neurologically that you can really lose consciousness is if you had a seizure or hypoperfusion or lack of blood flow to both your cerebral hemispheres. So if you have a big stroke on one side of the brain, you shouldn't lose consciousness unless you've had an old stroke that was big on the other side of the brain, or both sides of the brain are having strokes at the same time. The other thing is if you have a lack of blood flow to your basilar artery in the back of the brain, you could also black out from that too. So whenever patients have syncope, we always want to know what they were doing. The most embarrassing question is always asking if they were on the toilet, if they're doing number 1 or number 2, and then if they had any lightheadedness. And then the main thing is, to exclude cardiac causes. Do they have aortic stenosis or any hypovolemia? And so the first thing we always ask for is checking orthostatic blood pressures to see if their blood pressures drop when they go from laying down to standing. Even patients who are hypertensive, when you check them when they're sitting down and their blood pressure is 160, they can still have orthostatic symptoms. They could drop from 160 to 140 systolic and have symptoms still. So just because they're hypertensive doesn't mean that you shouldn't check orthostatics on these patients. And sometimes, the main treatment oftentimes are compression stockings. They even sell them at Fred Meyer next to the pharmacy counter. It must be a common problem. I actually wear them myself to prevent varicose veins from standing a lot, and they work great. For syncope, not for the varicose veins, maybe. My favorite disorder is transient global amnesia, only because we don't really have a good understanding of what causes this, but it's pretty profound. Patients usually have this sudden disorder of memory. It's often associated either with significant exercise or a stressful event. And patients are referred to as confused, but what they really have is the inability to make new memories. So they often ask the same question over and over again, like, where are we? And then you'll tell them where they are, and then 5 seconds later they'll ask, where are we? And it gets kind of annoying, but it's only temporary. And then once the attack kind of wears off, their memory goes back to normal. What they do know is there's no increased risk for stroke. They don't think it's related to seizures. Some people theorize it could be related to the veins in the brain, but no one really knows. My one patient that I had was, performing a solo concert, I guess, with his cello, and right afterwards is when he did the performance just fine, and then a few hours later is when he started to develop the symptoms. That was kind of interesting. So just to kind of summarize, history taking is, very important, if not the most important. The physical exam often is just to kind of confirm your history. You always want to kind of describe what the patient said and really define to yourself what do they mean exactly. Often, the witness account is just as important, if not more important. And the things you want to distinguish is this a focal deficit or is this a nonfocal deficit? Are these negative symptoms or are these positive symptoms? And then for the stroke point of view, you want to know when were they last normal, and how did this start? Was it sudden? Was it gradual? And how did it happen? Just complete plegia all at once, or was it over weeks that the patient started noticing numbness? And we've seen that before. And then was there any associated symptoms? And just to emphasize, imaging is great. We love ordering CT angiograms, CT perfusions, MRIs, but you always want to use those in conjunction with our patient encounter and not before. So I always try to look at the patient before I look at the scan when I can, because you can often be burned. You could be looking at some part of the brain that you think is where the problem is going without seeing the patient and think that that's the patient's problem, and then kind of bark up the wrong tree, I guess. And so in conclusion, treat all patients with the urgency of stroke until proven otherwise. So I'll be open to questions. Sure.
Just distinguish positive versus negative symptoms that you're talking about. I think I got it, but.
Sure. So the negative symptoms are basically loss of function symptoms. So loss of vision or loss of movement, loss of motor function, loss of sensory function. Positive symptoms are like twitching, tingling, seeing spots of vision. Okay, thank you.